Assalamu alaikum, doctor.
Okay. It's already 2 o'clock. Should we start?
Yes, doctor, we can start.
Okay, thank you. Assalamu alaikum. What we are going to talk about today is an important subject. It's important because of 2 things. It's not a rare event. It affects probably 1 or 2% of the population, but also it is a very scary type of experience for the patient, for the family, and even for some of the healthcare providers, because the event is very dramatic, especially the generalized seizures. So let's go first for the definitions. What is epilepsy? Epilepsy, it's a chronic, it's not something that just comes and goes. It's a chronic neurologic disorder. Its manifestation is, number 1, repeated epileptic attacks, epileptic fits, and the cause of it is paroxysmal, and paroxysmal means that it comes and goes. It doesn't stay all the time. It is paroxysmal, uncontrolled discharges of the neurons. So it is, the patient himself does not have control over it, and the internal control mechanism in the brain cannot control these paroxysmal discharges either. These neurons will fire within the central nervous system, gray or white matter disease. Now, the clinical manifestations that physicians and family sees ranges from major motor convulsion to a brief period of lack of awareness. It is characterized by being stereotyped, and stereotype means that it repeats itself in the same manner over and over again. Number 2, it's uncontrollable. So stereotype and uncontrollable nature of these attacks are characteristics of epilepsy. We go for definitions. What is the difference between a seizure, an epilepsy, and an epileptic seizure? Number 1, one seizure does not mean epilepsy. It's a paroxysmal event. It is attributable to an abnormal, excessive, hypersynchronous discharge from an aggregate of CNS neurons. Hypersynchronous means they are firing together. Synchronous means with each other. Hypersynchronous, over coordinated between each other, and that's why we are going to see, they will bring a high level of waves. These discharges come from an aggregate of CNS neurons. So it can happen as a single seizure, as we're going to see. However, epilepsy, it should have a history of more than 1 seizure. 1 seizure does not make the diagnosis of epilepsy. And the alterations in the brain increases the likelihood of future seizures. The alteration in the brain can be visible anatomically on imaging, and can be invisible because there is some alteration in the channels over the cell membranes that causes this to have a tendency to repeat itself. It is associated with neurobiologic, cognitive, psychological, and social disturbances, but it is not necessarily a feature of it. Now, an epileptic seizure is the transient occurrence of symptoms and signs because of an abnormal excessive hypersynchronous discharge from CNS neurons. Now, we should always remember that epilepsy is not contagious. It doesn't affect the rest of the family. It doesn't get transmitted to people who take care of the patient, and it is not a mental illness. Many epileptics are highly intelligent and functioning persons. It is not a cognitive disability. The neurologic dysfunction seen in epilepsy can begin at any time from birth, childhood, adolescence, or adulthood, and it may occur with cerebral palsy. It is an association between 2 diseases that are caused by a common cause. And the common cause usually in cerebral palsy is perinatal asphyxia, which leads to the symptoms of spasticity in the person, maybe some cognitive impairment, and the abnormal discharges in the neurons that is translated clinically into epilepsy. Now, attention deficit disorder or with hyperactivity, attention deficit hyperactivity disorder, sometimes it's associated with epilepsy and sometimes it's maybe an isolated type of disorder. It may be associated with some developmental disabilities and it may be associated with autism, but not necessarily. But the majority of people who have epilepsy do not have another impairment and may live normal lives. What's the prevalence and incidence of epilepsy? First seizure incidence in 100,000 population, about 20 to 70. Epilepsy incidence itself, which means that repetitive seizures, about 20 to 40 per 100,000. And the prevalence, those people who have ongoing seizures, is about 1.5 to 5% of any population. It is higher in some developing countries because of the prevalence of head injuries, because of the prevalence of poor health care. The cumulative adjusted lifetime risk is about between 1.3 and 3.3% of the population. How do we classify epilepsy? Epilepsy is a symptom. It's a wide range of symptoms. The seizures may begin focally in the brain from a single lesion location within the hemisphere. It is distinguished from the other type, which is generalized seizure, which is probably will commence in the deeper structures of the brain, the brainstem and thalami. Collectively, we used to call them the centroencephalon, the center of the brain. And they project simultaneously to both hemispheres. You're going to see that repeatedly during the lecture. So, focal onset seizures, as we can see in the drawing, there is one area in the cortex that is the source of seizures, and it accounts for over 60% of the adult epilepsies. And it may lead to simple partial seizures, to complex partial seizures, or to partial seizures with secondary generalization. On the other hand, generalized seizure start, as I mentioned, in the centroencephalon or in the thalami and brainstem. It's a subcortical origin that fires discharges to both hemispheres. That's why it begins in both sides. And there are some unclassified seizures. There is all the time, there is some change in the terminology. The new terminology for primary generalized tonic-clonic is the idiopathic generalized tonic-clonic, while the secondary generalized tonic-clonic, we call it focal to bilateral tonic-clonic seizures. Both of them deliver the same meaning. We come to more details about the classification. Those with focal onset, they start with the person aware, and then the awareness may be impaired or it may stay. If it is motor onset, it may have single limb convulsion and stop, or it may cause automatism if it goes to the deeper structures such as the hippocampus and the insula and so on. It may give some focal atonic or clonic or hyperkinetic or tonic. All of these are symptoms. If there is non-motor onset, again, there are some autonomic symptoms such as sweating, palpitation, hypertension, and so on. There may be a behavioral arrest. The person will be doing something and then all of a sudden he stops. There may be some cognitive, that he forgets what he's doing. There might be some emotional outburst. He may feel unnecessarily depressed or crying or rage. And there might be some sensory symptoms. He may feel numbness on one side or the other. Now, If we go to the generalized onset, we have the motor onset, again, tonic-clonic, tonic-clonic, myoclonic, etc. Myoclonic means in a group of muscles. Tonic-clonic affects the whole body. Non-motor onset may be a typical generalized seizure, atypical generalized seizure. These we can see in children with brain damage, or eyelid myoclonia. Now we have the focal to generalized tonic-clonic, and we have the unknown classification with motor onset, non-motor onset, or unknown. We go back to the partial seizures. Partial seizures, there is electrical disruption that involves a limited area in the brain, and the display here shows the anterior temporal, which is the most common place where the seizures may start. So the simple partial seizure, there might be some motor or sensory or vegetative or psychic symptomatology. Typically, the consciousness is preserved because it is simple, as I mentioned. The focal partial seizures is characterized by focal abnormality on EEG, and the focal abnormality we decided on of course, the electroencephalogram. I'll give a very quick description for it. We put a number of electrodes in specified locations over the scalp, and these electrodes, they pick up electrical activity, which is very, very small. It's measured in microvolts, not in volts. And then we send it into an amplifier. Now, each line in the electroencephalogram is coming from the change between two electrodes. Now, when we have adjacent electrodes, like the one that is coming, for example, frontal to temporal, temporal to occipital, and we find this abnormal activity that is making what we call a phase reversal, which means that this one is going down, this one is going up, which means that the electrode that is common in between these two channels is the source of the activity. So the focal partial seizure, we can localize it by focal activity in the EEG. Now, as I mentioned, the consciousness is typically preserved. There might be movements, rhythmic, isolated twitching in the arm or the face or the legs. There might be sensory symptoms of tingling, weakness. Any function in the brain may be simulated separately in an epileptic seizure. Psychic symptoms like this is a déjà vu. Déjà vu, it's a French word. It means that I've seen that before. And the person who has these psychic symptoms as a part of the simple partial seizure, the things that he is experiencing now, he feels as if he had seen them before, although they might be new to him. But that's a phenomena that we call it a déjà vu phenomenon. He might hallucinate, seeing colors, lights, etc., that are not there, or feeling of fear or anxiety. And usually it lasts less than 1 minute, and that's important. And maybe secondarily followed by generalized convulsive seizure. We'll talk about that later. Complex partial seizure, on the other hand, there is altered awareness, confusion, and inability to respond. So that means that it extended to the areas of awareness. And usually it's manifested by automatic purposeless behavior, like he may start picking at his clothes purposelessly, and he may start having some chewing movement, or he may be mumbling some unintelligible words. There might be some emotional outburst and may be confused with drunkenness or abuse of drug, or willful belligerence or aggressiveness. Complex partial seizure, the the first thing that the person may feel is an aura. An aura is part of the seizure. It is not separate part. And the reason for the aura is that it starts focally while the patient is still aware. So he knows, he experiences that. So by memory, he knows that this experience comes before he goes into loss of contact with his surrounding. Usually, the inferior horn of the lateral ventricle is over here, and we have the hippocampus below that. This is the temporal lobe, and this is the area which, if activated or if generates a focal activity, it causes a complex partial seizure. So, partial seizure, it may evolve into tonic-clonic seizure. We are showing here a cortical origin that may spread to the central structures, such as the thalami and the brainstem, and then it is fired back into the other areas of the brain, ipsilaterally and contralaterally. So, focal to generalized, as we can see here on the EEG, we have a spike, we call that a spike, restricted to one channel, and then gradually it increases in frequency, and gradually it becomes a spike followed by what we call a slow wave, and it spreads to several channels. So from focal to generalized EEG activity, that's how it moves. This is again, a partial seizure. What we see here, we see the normal activity on electroencephalogram, sinusoidal type of waves. We have some eye movements. These large waves are from eye movements. They are artifacts. We don't pay attention to them. But then we see that over here, we start to have rhythmic spike activity. This rhythmic spike activity is coming from FP2, F4. F means frontal, so it's coming from the frontal region. So this is a partial seizure that's coming from the right frontal activity. Then it continues, and we can see the highest spike, multi-spike activity coming from the frontal region and spreading to the other frontal region. So it continues the same. It moves from having just spike activity to some slow activity as well, with spreading to the other hemisphere. What are the causes of focal epilepsy, which is usually what we call a symptomatic epilepsy? It can be caused by a focal damage to the cortex by a stroke, and after the stroke heals, we have a gliotic scar, and that gliotic scar changes the properties of electrical activity in the neurons and cause them to hypersynchronize and have abnormal discharges. Sometimes it's related to a brain tumor or either local brain tumor or metastatic. Sometimes it's related to an infection such as a focal abscess, meningitis, or encephalitis. Or sometimes it can be due to head injury, past head injury or current head injury. Sometimes symptomatic epilepsy may be related to a metabolic problem. And the best example for that, non-ketotic hyperglycemia may cause focal discharges in the brain that may be suspected of having a focal lesion, but usually it is related to a metabolic problem. Other neurologic condition like mesial temporal sclerosis. Mesial temporal sclerosis is one of the major causes of partial epilepsy. Cavernoma, we talked yesterday about vascular malformation in the brain. The cavernoma does not usually cause a major bleed, but it causes leakage, and that leakage causes deposit of iron-rich hemosiderin near the cortex. It's an irritant to the cortex, and usually cavernomas are manifested by seizures and not by subarachnoid hemorrhage or intracerebral hemorrhage. And there are some genetic factors in symptomatic epilepsy. Now, generalized seizure, the electrical disruption involves the entire brain. It comes from the centroencephalon and it involves the whole brain. And it may be absence or what we call petit mal coming similar to the grand mal from subcortical origin. But if we look at the EEG, we find that it is starting on both sides at the same time, and it's giving a spike wave appearance on the electroencephalogram. It may be associated with myoclonic seizures. So there is an entity that is called juvenile myoclonic epilepsy. It affects the adolescents, and it is manifested characteristically by myoclonus in both upper extremities, and it may involve as well the eyes or the head for a short period of time upon waking up in the morning. There might be clonic seizures that affects the whole body. There might be tonic seizures, which is rare, but it causes stiffening of all muscles in the body. Or there might be some tonic-clonic, which is the typical grand mal, or atonic seizure, where instead of having stiffness, we have loss of tone in all the muscles, causes the person to fall to the ground in a drop-like attacks. So in generalized tonic-clonic seizures, there might be no aura. Notice here that there is no aura. The aura is caused by a focal discharge while the patient is still awake. Here we have a prodrome. The body is gearing up to develop a generalized tonic-clonic seizure. We don't know why it happens, but it might be just a mood change, just a sleep disturbance, or feeling lightheaded, or feeling irritable. All of these are non-specific generalized symptoms. Then comes the tonic phase, and the tonic phase, all the muscles will stiffen. Now the muscles that open the eyelids stiffen, and that's why the person will look staring. Usually with generalized tonic-clonic convulsion, the eyes are open. We use this as a differentiation between psychogenic seizures, because patients who have hysterical or psychogenic seizures, his eyes will be closed during the attack. Here, the first thing that happens is staring and generalized stiffness of the whole body. And then we have the epileptic cry. Why does it happen? Again, we have spasm in the diaphragm that forces the air out of the lungs, but also we have spasm in the vocal cords. So air coming from a spastic vocal cords will be manifested by a cry. And then there is incontinence because of pressure on the bladder. There is arching of the back as a tonic muscles of the paraspinal muscles. And then there is cyanosis because there is not enough ventilatory movements to clear the carbon dioxide, at least temporarily, from the lungs. Then we come to the clonic phase. And during the clonic phase, cyanosis remains, but then the clonic movements will affect the eyelids. The person will be blinking. Then will affect also the forceful air exit from the mouth. It causes frothing. The secretions that accumulate in the mouth will be pushed by the air that comes out of the trachea and cause frothing through the mouth. Then there is clonic jerks in the head and the whole body, and they are rhythmic and bilateral. So this is a generalized tonic-clonic seizure and used to be grand mal. So typically there's loss of consciousness, cry, fall, stiffening, followed by rhythmic shaking. The breathing may stop temporarily. Skin, nails, and lips may become cyanotic, but that's for only a minute. And loss of bladder and bowel control may occur. Generally, it lasts from 1 to 3 minutes, not more than 3 minutes, and it's followed by confusion, sleepiness, and forgetting of the event, because the whole cortex will be involved, and it will not register any memories of it, and it will be exhausted. That's why it takes time for the person to return to his ability to understand and be aware of his surrounding. That is what we call confusion. And that confusion also is typical of true seizure. We call it a post-ictal phase. It's a post-ictal phase. Now, absence seizures, or petit mal, it affects children. That's why they call it petit, or they call it petit in French. It means small, because it is not associated with the general major manifestation. But there is a brief loss of contact with the surroundings. And sometimes the brief loss of contact is very limited to a few seconds. And sometimes it cannot be detected unless the family or the examiner ask the child to repeat something that he had memorized, and all of a sudden he will stop, or he asks him to count, say 1, 2, 3, 4 to 10, and all of a sudden he says 1, 2, 3, 4, and then he stops and blinks, and then after a couple of seconds he goes 4, 5, 6, 7, 8, and 9. During which there is eyelid fluttering. And it's usually, as I mentioned, pediatric patients, and it may affect school performance. Why? A child who is having loss of contact with his surrounding frequently may not attend quite well to the school, to the explanation on the board or by the teacher. So this interruption in his attention causes him a decrease in school performance. And this is the typical EEG in absence seizure. It is what we call, this is a spike followed by a slow wave, spike followed by slow wave, spike followed by slow wave. And it usually has a rhythm of 3 per second. We don't see the lines here very well, but we can imagine this. I think in the next slide we can see it. These 3 are within 1 second. Let's see the next slide. No, the next slide, it shows the atypical absence seizure. And the atypical absence seizure, see these spike and slow waves, we have only 1.5. Between these 2 lines is 1 second. Between these 2 lines is 1 second. This is the spike followed by a wave. So we have 1.5 per second. That is an atypical, and it is usually has a more guarded prognosis, and it happens in young children who have epileptic encephalopathy. Now, the incidence by seizure type, the blue is the partial seizures. Near birth, there are a lot of partial seizures, and then they stop or they come to a nadir between the ages of 10 and 50, and then we have partial seizures coming up and becoming very common. Generalized tonic-clonic convulsion also, they are high during the early life, and then they come to a nadir between 20 and 60 years of age, and then they increase a little bit. Myoclonic and absence seizures are typical in the children and young adults. The differential diagnosis for epilepsy, number 1 is syncopal attack. Someone lost consciousness. Is that syncope? Syncope is caused by generalized lack of circulation to the brain. So that's why it happens only when the person is standing, and it results from global reduction in cerebral blood flow. And before that, the person becomes pale because of the low circulation to the subcutaneous tissue over the face, and it may be associated with nausea, sweating, and they may have a few jerks, not a typical myoclonus. It should be epilepsy should be differentiated from cardiac arrhythmia. And the typical thing is those people who have the so-called Adam-Stokes attacks. Adam-Stokes attacks is when we have a block, atrioventricular block. So the patient will be going on a ventricular rhythm only, and the ventricular rhythm may stop and cause the patient to have a sudden syncopal episode because of prolonged arrest of the heart rate. Migraine is different from epilepsy, and the slow evolution of the, of course, the typical between the two is sometimes migraine may have aura, sometimes epilepsy may have aura. The aura in epilepsy is very short. It's second or less than a second, while the aura in migraine, which is usually the visual aura, may, if the patient with migraine have an aura, it may last for minutes, and he is aware of it. It's a disturbance in his visual field. Hypoglycemia may cause seizures. If the person is diabetic and taking insulin, and he took an injection of insulin, he did not have a meal, then he may have loss of consciousness and seizure or intermittent behavioral changes. Narcolepsy is a different story. Narcolepsy is characterized by sudden sleep episodes. Catalepsy is sometimes associated with narcolepsy, and it causes fall to the ground without loss of consciousness when the patient is suddenly experiencing something unanticipated, or when he is very excited about, for example, winning in a game. He may be very, or when laughing, he may fall to the ground. But in narcolepsy and cataplexy, there is no loss of consciousness. Panic attacks are psychiatric problems. They are extreme anxiety, and pseudo seizures are the psychosomatic manifestations of a person either has a personality disorder or has severe anxiety. What are the etiologies? In infancy and childhood, prenatal and birth injury, inborn error of metabolism, and congenital brain malformations are the common causes of infancy and childhood seizures. In childhood or adolescence, there when we have the idiopathic epilepsy or the genetic syndromes that or head trauma, children fall frequently. Diagnostic workup for seizures. And